All right, everybody. So we're going to actually do a second training example today. So we're going to leave the world of anti-diabetic medications. And we're going to go into the world of medication use during pregnancy. And what we're particularly going to talk about medication use during pregnancy is ondansetron and other anti-emetic medications, which you might say was sort of the birth of the modern FDA in terms of issues of importance, nausea and vomiting in pregnancy. It's fitting that we are able to talk about that today. So let's first talk about why we might even care about surveillance during pregnancy. So antiemetic pharmacotherapy has long played a role in treating nausea and vomiting during pregnancy. I'm not even going to try and pronounce this condition. I'm just going to say extreme nausea occurs in less than 3% of pregnancies and is the most common reason for first trimester hospitalization. Ondansetron is a widely prescribed medication that's used off-label for nausea and vomiting during pregnancy, despite the approval of another oral antiemetic medication, particularly for this indication. And so the goal of this is to teach you another tool that we have. This is particularly geared towards descriptive analyses of medication use during pregnancy. One of the limitations of our tool is that we're looking at pregnancies that actually result in a live birth. And so that's something to keep in mind during this talk today. So a couple of the same questions about what we're going to look for. First, we're going to start out with the general pattern of use in pregnant women that actually give birth. We're also going to look and see if that general pattern differs when we compare a pregnant population to a non-pregnant population. The idea being, is there anything unusual about pregnancy that's creating this pattern of use? And so again, we're going to use that same tool that we used before, that same computer program, the cohort identification and descriptive analysis query to translate the safety questions here. So we're going to go back to our stoplight rubric from before, which is to say, is the Sentinel Distributed Database suited to actually answer this question? So we're going to go through, and again, we're going to think about our exposure of interest, which in this case is ondansetron. And so we're going to look at it. It's an antiemetic that is self-administered and is a prescription oral medication. So that gets a green light, and we can continue to work through that in our system. So let's talk about these current capabilities. First of all, what is a live birth utilization query? So this is, again, it's a tool or a computer program. It assesses medication use among a group of pregnant women who deliver a live-born infant, and then a comparison group of women who did not have evidence of delivery during that same time period. So the first thing we do is we create what we think of as a pregnancy episode. This is a period of pregnancy. And we can do that among either a general population of women or an indicated population of women. What I mean by an indicated population is a population of women who also have evidence of a particular type of condition. So then we're going to use that episode of pregnancy to create a comparator episode of women who have not had a live-born delivery during that same time frame. Then, once we have these two episodes of periods of time of women where we have coverage of their pharmacy information, we're going to look and layer medication episodes on top of that. And we're going to see whether there's an observed difference between the pregnant cohort and the non-pregnant comparator cohort. And then we're going to output all that information, which we're going to stratify by maternal age at the point of live birth, the year of delivery, and also by trimester. So let's look at how we build this query. What are these specifications, again, that we're interested in to get to the point where we say this is a period of pregnancy? So the first thing to note is that gestational age is not documented in the claims data. So again, because we're having secondary uses of data for other purposes, primarily billing, we actually have to construct that pregnancy episode. And we do that by deriving it. And the first step we do is we look for the actual live-born delivery. So we're looking in women's records and we're saying, okay, where is there evidence of an actual birth? And that's the first thing that we're looking for. And then once we have that live-born delivery, we're going to look for a period prior to that point and say they have to be continuously enrolled, they have to have medication benefits, and they also have to have medical benefits during that period of time so we can actually capture their information. We're going to also look for a washout period, which might sound a little silly. What we're washing out here is we're looking for a new evidence of delivery. What we're actually doing is we're taking out errors, essentially. If we have women that have codes for live-born delivery that occur within 3 months of each other, we think one of those codes is an error. And so what we're doing here is we're basically just scrubbing and cleaning our data to ensure that we have a unique delivery period where we haven't had another evidence of a birth within a period of time that's nonsensical. So then what we're going to do is we're going to figure out with that live birth if there's any adjacent codes that might indicate that the birth is either a preterm or a post-term. So there are codes that, for example, indicate that a woman is given birth at 34 weeks or 32 weeks with a particular extreme preterm codes. There's also codes that indicate that it's been post-term. And part of this whole point is to identify the period in which the woman was pregnant. And so we're starting at that live-born delivery, and we're subtracting from that point to get to the point where we have a pregnancy episode. And so that episode may vary depending on whether they have a 40-week gestation or a 42-week gestation or a 35-week gestation. And what we're doing is we're looking for codes right around their delivery to help us to understand that piece. Once we actually establish that this is the date of delivery, we're going to record that information. We're going to record the year of the delivery, and we're also going to record the mother's age in integer time, or integer years at delivery. Then we're going to look back, and we're going to have a pregnancy duration that we assign to that, and we're going to assign a pregnancy start date. So again, a 40-week gestation is going to get basically a typical assignment, 273 days. But if I have evidence of a preterm code, I'm going to assign a smaller amount of days because I'm going to think that that woman actually came to term and delivered at 36 weeks or 35 weeks. Or conversely, that they had a post-term code indicating they went to 42 weeks. And so that assignment of my pregnancy start index date is going to be dependent on the codes that I see surrounding that live birth. Then, from my pregnancy start date, that's where I'm going to include additional inclusion and exclusion criteria in case I want to see whether this is an indicated population versus a general population. So I might want to understand if there are high-risk pregnancy populations. So for example, women that have a history of hypertension, or that have a history of diabetes, or that have a history of any other kind of condition that might cause more concern. I can use my inclusion and exclusion criteria here to look for those particular subgroups and identify them as such relative to their pregnancy start date. And so, as before, we're going to go through and talk about the main parameters that we have. And so we have our general query period. We're going to also look for women of childbearing age. We're going to have enrollment requirements. In this case, we have a 480-day enrollment requirement. The reason why it's longer is I'm going to have to at least include my pregnancy duration and then any inclusion or exclusion I have before that. So that's where that 480 days is. You can take the 273 and say, well, that's a standard 40-week gestation, but if I have a 42-week gestation, it's going to go a little bit closer to 300, and then I'm going to add time in for any of my inclusion and exclusion criteria, and that's where I get to my enrollment requirement. That pregnancy duration is, again, saying, this is what I think a typical 40-week pregnancy is. The pregnancy duration adjustment is a period of time around that live delivery code when I'm going to look for those pre- or post-term codes. And that's going to help me to then basically refine my understanding of the length of that pregnancy. And in this case, for the parameters, there were no special inclusion or exclusion criteria that were attached to this particular training query. So how is that gestational age adjusted? Let's talk about it with actual figures of women. So first we have Maria. So she's a 35-year-old woman who gives birth in 2010, and she has a normal delivery code, and she has no other unusual codes in the 10 days, either plus or minus that normal delivery code. So for her, I'm going to assign a 40-week gestation of 273 days, and I'm going to establish that she has a particular pregnancy episode. In my second row there, I have a woman who is a 28-year-old who gives birth in 2014. She actually has an additional code aside from the delivery of having extreme prematurity. And that additional code changes the number of days of pregnancy duration and reduces it from what I would normally consider the 40-week 273 down to 196 days. That's an example of my preterm codes. Louisa is a 22-year-old woman who has a delivery and then also has an additional code to indicate that she has a post-term pregnancy. And so her duration is then adjusted from 273 to 287. All of these date adjustments have actually been validated via that paper that was sort of referenced at the bottom on the prior slide. And so all of this is coming from an approved or a validated algorithm in the ICD-9 era that has established these numbers of days appropriately. So now that I have my group of pregnant women who have live births, I'm going to look to find matches for them. And what I'm looking for there is I want to match my pregnant woman that resulted in a live birth on another woman who doesn't have evidence of a live birth during that same time period. I'm going to match them on their integer age. I'm going to match them on the time frame in which they delivered. And I'm going to match them on site. I'm going to match the time frame of the pregnant woman when she delivered to the time frame when the other woman doesn't have an indication of delivery during that time. And I'm going to match them on the database they came from. And so here you have in the illustration at the top, you have the woman who is pregnant, and she has a pregnancy start date, and she has a live-born delivery date. And then you have the woman on the bottom who is her non-pregnant comparator. She has a non-live birth start date. She has a non-live birth end date. And then we have this period of trimester that's divided according to the pregnant woman's pregnancy start. And so this is sort of the setup for then how we're going to record medication use during pregnancy. So the first piece of this is just to establish these episodes and the comparator episodes. And then now we're at the point we're going to layer on top of that the actual medication usage. So we're going to call back to our presentation this afternoon about how we define treatment episodes. It's the same. So that's the good news. You've already learned how to do it. So we're going to start with our drug of interest. In this case, it's ondansetron, the oral formulation of it. This is not going to have a new user criteria, meaning that I want to count any use of ondansetron regardless of whether it's new use or not. So I have no requirement at all for them to be, this woman to be free of ondansetron for any period of time prior to when I'm going to start counting. I'm going to use standard stockpiling as I did before. I'm going to have a 10-day episode gap where I'm going to consider you continuously exposed to this medication, and I'm going to use a 10-day exposure extension period. And so, as before, once I parameterize my query, so once I set my input parameters for my computer program, and I do my testing, and then I send out to my data partners, and then they run the query on their data systems, and they review those results, and then they send them back to us, and then we aggregate those, then we're going to get to the output. Here's a visualization of what those ondansetron episodes look like when they're added. So we have ondansetron in our pregnant woman, where she's been taking it for a period pre-pregnancy in her first trimester and her third trimester. And then we have our non-comparator, or our, non-pregnant comparator, where she's taking that during the equivalent period. She's not pregnant, but during her first and second period, or first and second trimester. And then I'm going to look at the characteristics, this output of what I've got. And this is actually a query that was run. In the very first slide, we have the link to the paper that this comes from. So this is real data that's been published. So the first thing to look at is how many women do we have where we had a unique pregnancy episode, and then how many pregnancy episodes are there. So one of the things you can look from that is that women can have multiple pregnancy episodes. So in the tool, you can actually have multiple pregnancy episodes that resulted in multiple live births but have less women. You can look there at the stratification by calendar year of delivery admission and also by maternal age. And so you can see sort of what does this cohort look like in the Sentinel Distributed Database. You can understand whether this basically whether these pregnancies, whether we're seeing women who are older who are giving birth or younger that are giving birth, or whether there's been any change in birth. Some of the changes over time may reflect data partners coming in and out, so you have to sort of understand what you're looking at when you check out the descriptive characteristics, but this is available. And so then the question here, the originating question for why this was answered or asked at all was, what does ondansetron use look like during pregnancy? And so here, the total pregnancy episodes in this particular query that ended in live birth were a little over 2 million. So we had a large denominator to start with of potential pregnancy episodes during which ondansetron could be used. There at the top, you see any antiemetic. That's a grouping of a large number of medications. And then you see a particular medication there, which is the indicated medications. This is the medication that's approved for nausea and vomiting during pregnancy. And then you see ondansetron. And you can then look across the columns and look at the use during the 90 days preceding pregnancy, the first trimester of pregnancy, the second trimester of pregnancy, and the third trimester. And what you can see from these data is that ondansetron is used much more prevalently than the approved medication for nausea and vomiting during pregnancy, meaning that there's more ondansetron use than the actual labeled indication. And in general, that the ondansetron use comprises a large amount of the total antiemetic use, so that essentially it's a non-significant portion that's attributable to ondansetron. So what we can do here is we can also compare, and this is data actually from a published work, so it's why it's a little bit hard to see, treatment and controls by the maternal age at the point of delivery. So really the thing to look at, or what we want to point out to here without having you actually try to read these slides, is ondansetron use is much lower in the non-pregnant control population as compared to the live-born delivery population across all age groups. So in terms of the pattern holds regardless of maternal age, in that ondansetron is widely used off-label during pregnancy. And so we'll this is our very brief sort of introduction to the pregnancy tool, but we'll go through and think about some of the considerations that we have in using the pregnancy tool or the medication exposures during pregnancy here. This is a paper that essentially examines the prevalent use of a large number of medications for use during pregnancy, and this specifies a bunch of the algorithms that we utilize in our pregnancy tool. Something to point out about our database is that we have older moms as compared to the national average. So you can see there from this paper that we end up with a larger percentage, and this was run during the mini Sentinel era, which was why it's labeled mini Sentinel, but mini Sentinel became Sentinel. So you could see that women over 30, we have a greater representation of deliveries in our system versus the national average. So just something to keep in mind. We also have less preterm and post-term delivery, preterm and post-term delivery than the national average. So we're close, but slightly under for post-term. And for preterm, there's a somewhat significant difference between less preterm delivery in the mini Sentinel population or the Sentinel population versus the US population. And so why do we utilize this tool at all? So use of medications during pregnancy is something that mostly can only be done in a post-market environment because there are very, very few trials that take into account pregnant women in a pre-period, a pre-approval period. And so most of what we're doing here is really descriptive work to say how many women who appear to be pregnant are utilizing these medications, how are these medications being utilized relative to a non-pregnant group of women who didn't have evidence of a live birth. Again, like before, we can utilize the same tool, which means that we can utilize complex definitions of both the exposure of interest and also the inclusion and exclusion criteria to say something about these women. It stratifies this cohort automatically, our tool does, by maternal age at delivery and also the year of delivery. And that we have this comparison idea between looking at a live birth population and a non-pregnant comparator and matching those two populations on maternal age in integer years, on the site, and on the time period during which they utilize this medication. So it allows you to think about whether it seems as though pregnant women have a different pattern of use than other women. And so again, this is what we would think of as a level 1 query or a descriptive or a feasibility query. And we have the same general turnaround times as you saw before for our level 1 queries. So one of the things to remind everybody is gestational age is not actually readily available in claims data. So this query is all predicated on this algorithm that derives the pregnancy period using the anchor point as the actual delivery. And so everything works roughly off that delivery. As a result, the tool is limited in that it doesn't assess pregnancies that don't result in a live-born delivery. And so it's limited to only those that do. The other piece about this is this tool is purely descriptive in the sense that it's exposure only. So we are not looking here for the exposure and then linking it later to an outcome that may result from the exposed pregnancy. One of the things that we're working on, one of our initiatives, is to develop what we call the mom-baby linkage or the cohort linkage. And so what that is saying is really the outcomes of interest generally for pregnancy or medication usage during pregnancy are related to the infant more so than the mother. And so most of the times the outcomes of concern are things like birth defects or other types of things that are require you to be able to tell which moms belong to which babies. And so right now we're working with our data partners to establish that linkage. And when that linkage is established, we will use that in conjunction with this tool to be able to do some comparative questions of interest and some inferential questions. But for the time being, this is really only a descriptive query that really just deals with what is the pattern of medication use during pregnancy. And so with that, we have time for questions, and we're running a little bit early, and so we'll be able to potentially wrap up early. So take any questions from the audience. So the question is, can we use the data to look at miscarriages and use of drugs? So there are various ICD-9 codes and 10 codes that deal with non-live birth outcomes. So spontaneous abortion, missed abortion. There are other types of codes. All of those require just the time to go through and validate what the time point is relative to when the pregnancy started. So essentially that's all methods work to be done, where somebody does, all the data are there, it's just deriving that algorithm and then going through and validating it, usually by doing chart review or something like that with respect to the timings. And so essentially there are outcomes that do deal with the non-live birth. We just haven't gone through and then utilized outcomes. And really now it has to be in the ICD-10 era that go back and look and say, okay, if this is the outcome that occurred, then we expect that the pregnancy start date was X. So when I'm talking about chart reviews, what we would do is, so when we get these data at the Sentinel Operations Center, they're actually aggregated. So they aren't patient level data. So they're coming back from a data partner and saying, we have 50 women that meet this condition, or we have 20 women that meet this condition, et cetera. But what we would do if we wanted to do a chart review is we have one of those programs I showed, and actually let me see if I can page back to it, in the query sequence at the last part where there is the, I apologize for not having it readily available. There we go. All the way over there on the right side of the screen is what we call those follow-up queries. And so what we do there is we parameterize a query that goes to the data partners and say, of the women or of the people, it doesn't have to be women because it doesn't necessarily have to be associated with the pregnancy query, it could be the other queries. Of people who meet this condition, we create sort of a patient list of who those folks are. And then what we would do is we would go to our data partners and say, there is an interest in going to a chart review for these patients. Can you tell us if these charts are obtainable? And then they would go out usually to, it depends on the type of system they are. If they're national claims insurers, they typically use a vendor. Otherwise, if they're an integrated delivery system, they have access to some of the complete records there. And they would go and try and find those charts. There's a percentage of them that are always going to be unobtainable. But if they can find them, then we would go through a chart validation procedure where you would have a case definition and you would have adjudicators look at that case definition and say, what's actually happened in this chart? Is it reflective of this code? And then we would be able to go through that exercise to create algorithms that were appropriate. Questions in the audience or questions on the line? So the question from the WebEx is, who can submit a request for a query to be run, and why are the results usually returned to the FDA? Are they also sent to the originating requester? So in general, with the system that we're describing today, the Sentinel system, the main requester is the FDA. And so they're the investigator of interest. And so when we return the results to the FDA, that's the equivalent of saying I'm returning it to the original requester. Oftentimes the FDA authorizes another party to be an investigator and to execute a protocol on their behalf. And so those are usually principal investigators or epidemiologists at academic centers or at the data partner sites. And in that case, we're returning the results not only to the FDA, but the person who the FDA has asked to be a principal investigator on their behalf for a particular exposure outcome of interest. If we are utilizing Sentinel in what we think of as sort of the non-Sentinel uses of the Sentinel Distributed Database, using something like the Reagan-Udall Foundation or utilizing something like the NIH collaboratories, then those would be the requesters of interest, and we returned results, we would return results to that requester of interest. So I say FDA only because the vast majority of the Sentinel-based queries are returned to the FDA. So another question from the WebEx: Could this technology be used for determining potentially new indications for existing drugs via the drug exposure versus time and favorable clinical outcome of an existing patient condition? Okay. So essentially, I think what this question is asking about is about the ability to see potentially new off-label uses of existing drugs for particular conditions. One of the types of queries that we have with the L1, the descriptive query, which we didn't actually touch on today, but we have the ability to do, is to look for, prior to a dispensing, for a period of time before, the top 10 outcomes or diagnoses of interest that pop up in terms of a frequency count. And so, and it doesn't have to be 10, that it's actually user specified. But that's a type of query we have where you might look if you thought that there was off-label use occurring, but you didn't know how to identify that off-label use because you didn't understand exactly how it would be coded. You could run a query of that nature and then be able to glean that information out. If there were off-label uses that one knew of and suspected in advance, then you could think about how to actually code those up appropriately and bring back information on those potential off-label uses. So that was one part of that question. The question seemed to be in two parts. Maybe we can ask the requester if that answered the question or not. Go ahead. So the FDA is committed to increasing the transparency of queries that are asked prior to there actually being results. So right now, what we have available on the Sentinel website are for queries that have been completed. For the results that have been created, the results get published to the Sentinel website. But there is a sort of a movement underway that we're in the middle of in creating sort of transparency and web pages to support, which is to say, can we identify the queries that are asked before the actual results are in, when we're just saying, you know, this came up, and we want to know if a question has been asked at all. And so we're working with the FDA to get that list available to the public and get it posted to the website. But in that, I still am not quite sure if there will be a narrative associated with the whole sort of story of where this came from, but it will be more information about exposure outcome pairs of interest and questions that have been asked of the Sentinel Distributed Database prior to the actual formal results being ready. So the FDA has a contract with CMS through an interagency agreement to utilize CMS claims data just the same way that we utilize this data here to answer safety questions of interest. Typically, though, those aren't reported out in a website where it's easy to find that information. But in PubMed, essentially, there are particular studies that are done in the CMS database that are authored by FDA authors. And when that occurs, it's because of that interagency agreement between the FDA and CMS to actually get something out there. How do you aggregate the results? Through meta-analysis is the question. So we aggregate the results not through meta-analysis, because when we are pulling data out of the cohort identification and descriptive analysis tool, the data that's coming to us is about the particular cohorts and saying, these people met the following conditions, and we count their new use and we count their follow-up time. And so then that information gets aggregated, so we get a number of new users, we get a total amount of observed person time, and that can be aggregated across data partners. We always have a record of where that individually comes from, but in order to actually perform our inferential queries, it's aggregated, and then that aggregated analytic data set is what is utilized by the inferential designs here, which are the propensity score, matched or stratified tool, as well as the self-controlled risk interval design. When we have the data for some of those supporting, or some of those queries that we'll talk about again, we meet in February, when there are analytics, one of the things we always have to consider is what we can do in a distributed setting versus what we can do in a single database setting. And Jeff touched on that earlier today, referring to work from our colleague, Dr. Darren Toe, about distributed analytics. One of the key things to understand always is whether it is possible to combine these data in a way other than meta-analysis in order to perform these inferential sort of estimates and to get the hazard ratios, the hazard ratios, the odds ratios, et cetera. And so for the time being, we don't have a need to perform meta-analysis for the types of designs that we have. That's not to say that we wouldn't potentially do it in the future, but the designs that we have don't require it. Yes, ma'am. So the question is whether we ever look at it as comparative populations across multiple sites. So one of the things that we can do, but we are sensitive to, is site-specific analyses, where we can run the same analysis on only one of the data partners and compare that to another data partners. Our data partners are a fairly heterogeneous size. So some of the data partners are very large, and some of them are rather small. And so you end up with effect estimates and confidence intervals that are not necessarily comparable as a result of some of those size concerns. But we usually run, when we do an inferential design, we run site-specific analyses and forest plots to understand whether there's any particular data partner that might seem out of the norm, which then might cause us to think about whether there is differential coding or something that's occurring that's unique to that data partner that might be driving those results. So we do that, but usually we do that behind the scenes after the inferential design has been requested. So the question was pregnancy. How do you handle the time lag of the diagnosis given that pregnancy diagnosis comes after pregnancy and those unidentified pregnant women can or may use a drug? So the question here relates to the time lag of the diagnoses that come after pregnancy. And so one of the things that's true about our data in general is that we wait for claims to settle. This is something that Kevin Haynes talked about earlier today. So pharmacy dispensing data is usually quite fresh, and so we can get that much quicker, the medication data, than the actual medical benefits data that would come with a live delivery, for example. So our data for our medical encounters is typically 6 months to 9 months old. At the time that we get it and arrives in our system, and by that time the pharmacy data would have is ahead of that at that point, and so we're not as worried that we're going to miss a medication usage episode that occurred because we're seeing the pregnancy but we're not seeing the medication usage. We also have the ability to set our query periods if we ever had concerns of that nature, where we would try to capture queries for which we thought we had complete coverage. So generally, that particular time lag is not a concern of ours. So another question for pregnancy, can we use the data to look at birth defects as an outcome given drug exposure? So that was sort of what I was getting at, is that we will, stay tuned. So we're building, again, that mom-baby linkage, which requires there to be a match between a mother and an infant. And then what we can do is we can run a query like this, an exposure during pregnancy query, and then we could follow, because again, we would know that that mom and that infant were linked, the infant for particular outcomes of concern for a period after their birth, and we could then perform inference on that data. But as of now, we need to actually build, we have built it in the past, I should say, in a one-off capacity. But now what we're doing is building it as part of the distributed database, where the idea is that it is always present. And so you could always ask at any given time, and you would have that linkage available to you. So we have actually done linkages in the past. It's just they've been one-off in nature. And now we're actually building it as a permanent piece of our infrastructure. So I think we're a little bit early for the wrap-up, but if there's no more questions, I'll bring up Rich, who can take it home.
Thanks, Judy. Thanks to all of you. I had the privilege of listening to the whole conversation. I don't think we've ever had as thoughtful and engaged a set of discussants in the audience. So thank you for being so thoughtful about this. It would help us enormously if you'll fill out the questionnaires that are on the chairs there. We have some extras. Takes only 30 seconds, but if you'll tell us your candid thoughts about what was useful about the day, what wasn't useful, what you think should be added to future trainings, that'd be terrifically helpful. We'd be happy to follow up with any of you individually. You can do that by contacting any one of us, or on the Sentinel website. There's a link so that you can contact us. It's info@Sentinel. But we'd like to keep an open channel with all of you. Any last business anybody would like to bring up for discussion from our data partners, from our FDA sponsors? Okay, that's good. So thank you so much. And we'll look forward to keeping in touch.